Mm.
Everybody got that?
Yeah.
Okay, awesome. Okay, so first of all, welcome everybody and thank you for attending this online gathering, meeting, whatever we want to call it, conversation, which is bringing together creatives who are working on the project, which is I See Song, an interdisciplinary play that we are producing, and it's going to be on at the Camden Fringe at the end of the summer. And also, we have two special guests with us today who are going to support us in our conversation around the topic of endometriosis, because that's one of the key things that we look at within the scope of themes in the play. So, thank you so much for being here. We'll start off with introductions and then we'll get into the conversation. So, first of all, I hope that the noise in the background isn't too disruptive for you. Um, and secondly, I am Pid'or. I am the writer and director of the play I See Song. Um, I have the incredible honor of working with a phenomenal group of people who are helping me to bring this story to an audience. And the aim of the play is to open up conversations around really difficult subject matter, which many women experience in their lives. And one of the key ones that we look at is endometriosis, chronic illness, and how that can affect the body, how that can affect our relationships, how that can affect the trajectory of our lives, and how often these things are sort of kept within and not spoken about publicly for various reasons. And we want to bring these things to light and we want to have conversations and we want to encourage conversations because we feel that very strongly that these are things that need to be out there so that people can get the support that they need, and so that people understand how to support. Because I think that's also something that we don't talk about as allies. How do I support somebody in the situation that they're in? The play looks at the stories from a dramatic standpoint, but also looks at the experiences of the characters somatically as well. So it's interdisciplinary, lots of singing, lots of dance, lots of poetry. So it's an exciting piece, but it's more exciting because it means something and it's doing some important advocacy and political work in the theatrical space. And that's me. I'm going to hand over now to Kiara to present yourself.
Hi, I'm Kiara. I am the actor playing Z. To this character, they are Wrinkles' friend, Kathy's friend, and really fights for all of their friends, but mostly has a very soft spot for Wrinkles. And they go to all of the doctor's appointments, all of the read all of the research, and really try to fight for Wrinkles's diagnosis and for her health as well. Z is the sort of character that they've got their own things going on, but really generally just finds it's just generally they're more for their friends than they are for themselves. And yeah, I guess my curiosity is how much power do people other than the patient or other than the person experiencing the chronic illness have? Do they how effective is their advocacy? So yeah, that's me.
Thank you, Kiara. Over to you, Pollyanna.
Hello, I'm Pollyanna. I'm the other actor who plays Wrinkles. I'm the other friend of Z's. Wrinkles, she is the one who has endometriosis in the play and is diagnosed with endometriosis, and we kind of follow her journey physically, emotionally, and platonically, really, and how it affects her friendships more than romantic partners, but just and school system and everything, and herself and her experience with the hospital and NHS and medical side. So yeah, you've got like the school institution, the medical side, and then personal relationships as well and personal experiences in regards to endometriosis. So yeah, I guess I just am very curious to try and understand what is it like and what do people deal with on a day-to-day basis. What are they met with? What is the response? What is the attitude? What is the around endometriosis, and why is it a bit of a battle, and why does it take so long for people to get diagnosed as well? Because she gets diagnosed at 33, I believe. So yeah, it's a long time to not know what's going on.
Yeah. Thank you, Pollyanna.
Thank you. Yeah.
Go for it, Gurpreet.
Shall I? Yeah.
Yeah, please do.
So I'm Gurpreet. I'm the author of this little collection. I think my background is blurred, so it's kind of like
Show it here
not
for
giving
you.
you that. Yeah, there we go. I'm the author of this poetry collection called Pain and Other Inheritances. I've been called a very vocal advocate for endometriosis, and I've given a TED talk about how medical systems and the medical profession have actually failed women where endometriosis is concerned. It's on YouTube in case anyone is interested to watch it. I offer 3 concrete steps and solutions to doctors on how not to dismiss women who actually have endometriosis and come to them for help. I have also written op-eds on the pain gap in endometriosis pain management, and why when women complain of pain, particularly related to endometriosis, they're not taken seriously. And all of this advocacy has actually paid off in a big way because I firmly believe that for any kind of change to occur, a lot of policies around the institutions that we are involved in have to change. It because the policy environment is going to enable a lot of the other support systems to actually work. Policies also enable healthcare access. So, for example, I'm a Singaporean and currently based in Singapore for a few months. One of the things I've noticed, and this is probably what you will see with the NHS, I suppose, as well, is the fact that there are different levels of insurance that will come on board that will ensure who can actually gain access to certain levels of specialized care and certain levels of not specialized care. And this is crucial because when you are in an acute phase where you are in pain, you can't walk, there's so many different factors that are going on with your body, right? Access to care gets hindered by various kind of administrative, kind of levels that are there. And the second thing where policy also matters is of late, there has been a lot of, discussions about well-being and mental health. But the typical cost of seeing a mental health specialist or a counselor or a therapist goes up in the hundreds if you're not, subsidized or if it's not covered in the insurance. A lot of endometriosis patients, particularly because we are women, we are already kind of at the bottom rung where pay is concerned, where careers are concerned, and we'll kind of talk more about that later. So a lot of my advocacy is focused on getting policies to change so that women and patients can actually bear the benefits of that, can have access to care, can actually avail mental health, they can avail physiotherapy. All of that is accessible and affordable, because if you put in all the medications when a patient is, when a woman is diagnosed with endometriosis, or even before, when she's managing her symptoms, medications cost a bomb,
Yeah.
you know? Yeah. So it's huge. It's a huge burden, emotionally, physically, mentally, financially, for the woman to carry. It's huge. And I don't think any survivor is going to be able to adequately sum it up like in one word or a sentence, because it's just too much. It's too much. Yeah. So I think I'll stop there.
Thank you. Thank you. I'll hand over to you.
Okay. Yeah, so I'm Dr. Tampa, Dr. Pid'ange Tampa, family doctor, grew up in the UK, worked in the NHS for about 10 years, and then I moved to Canada. Yeah, graduated 2014 as a family physician, but I was in medical school beforehand, and then subsequently worked across East London, Essex and Kent, and lots of different settings. So yeah, I've got some experience of seeing patients with endometriosis and at different stages and different challenges that they face. And yeah, I'm happy to contribute my experience in any way that I can. I'm going to try and be as balanced and fair as I can, but I'll be honest. I'll try and sort of give out my perspective and sort of acknowledge some of the challenges that patients face, but I think it's across the board. It's not just in endometriosis, but maybe for women, it can be more difficult, especially when it comes to advocacy and access. But I'm happy to sort of go through that and just, experience, and try and understand your experiences as well, and to try and inform my, how I practice.
Thank you. So it's going to be a very interesting conversation, I think, for the reasons of where you're both coming from. And for us, that's super useful because we do look at this within the scheme of the play. We do look at the character's journey. Although it's not the whole play, we do try and reference the journey of the young person in the classroom who's having awful experiences, but is shunned because they're dramatic and they're being too much, and whether that's their peers or the teachers, and it's like, this again, you do this every month. To the young woman who's just trying to live her life as a productive member of society and not necessarily being able to the patient in the consultation who has gone to various appointments only to find, when they're almost at midlife, that they're now being diagnosed, and now they're being told, well, this is a really serious thing, you need to take this seriously, where they're kind of like, I have been, it's not me that wasn't. I'm really thankful that you're both here to offer us perspectives from both sides and to give us a balanced view, because we want to present that within the play. Because I think sometimes, particularly with creative work, I find we can get a very black and white presentation of situations. And I don't think it is that. And I'm aware that there's suffering on one side, and there's also, I think, Dr. Tampa, you can tell us a little bit later, there's probably also some technical difficulties in terms of the way things are set up for practitioners in terms of what they can offer or what they have available to them, but you're more expert to tell us about that. So I figured that a way in could be that we could take a reading from your book. So I'm just going to share this book on screen. And I got a copy of this book, Pain and Other Inheritances, Surviving Endometriosis. And it's a phenomenal read, just to have an understanding of one individual's experience, lived experience of surviving. I'm going to use that word because I think it's the right word, or a good word for it, surviving endometriosis. And what I love about this book and what I appreciate about this book is the holistic presentation of the experience. So the personal, the social, as in with family, with friends, the medical, the sections on it's just a lot. And also the spiritual. I'm really thankful that you've written it. I want to share a section from the preface. I won't read it all, but I'm going to share that, and then I'm going to ask what lands with you all and where we want to start the conversation, really. Gurpreet writes, this silence becomes even heavier in the context of Brown and South Asian cultures where women's pain is often minimized, where endurance is demanded, suffering is lauded, and where speaking openly about the body is treated as shameful. Women's reproductive health is steeped in gender biases and misogyny that gets exacerbated in conservative and traditional cultures. In my own family, I was met with disbelief, dismissal, and blame. That is how deep-seated these biases and prejudices are. Doctors told me my pain was exaggerated. Neighbors whispered it was just a nuisance. My own country, Singapore, turned away from me when I needed its kindness the most. For years, I lived in excruciating pain that defies language, in tear-stained and blood-soaked sheets, in hospitals where my agony and suffering was measured with emojis on a chart, in a body that rejected intrusion and screamed for relief. Endometriosis took from me my health, my dignity, my career, my sense of a future, my dreams, my goals. At 28, I did not think survival was possible, and I ended up in a wheelchair. I went through several surgeries, nerve blocks, and ultimately a total hysterectomy. This collection is the testimony of that survival. It is a personal archive of what it means to live with endometriosis in a culture that does not name it, in a medical system that does not believe it, in a world that refuses to see it. It is also a record of transformation, from brokenness to voice, from silence to defiance, from loss to inheritance, and the messy, uncertain in-between liminality. I wrote these poems because I had to, because the girl and woman I once was needed them, because somewhere out there, another woman is sitting in a hospital bed, all curled up on the floor, thinking she is alone in this. She is not. This book is for her. It is for every woman whose pain has been dismissed, whose body has been doubted, whose voice has been silenced. It is for the 190 million and the millions more who have not yet been heard. And I wanted to start with that because I feel like that says it all. And it's also why we are putting this play on.
Can I just say thank you, Pid'or, that was beautiful, and thank you for giving it voice, for giving it heart, and for putting it out there. Like I said, it's so shrouded in a lot of these taboos and silences that if your play, through all of this, through the poetry that I've written, through my experiences, if your play is able to just even impact one person in the audience, probably has been diagnosed or has endometriosis, then I think that the purpose of everything would have been achieved, right? The
Yeah.
advocacy, the voice, everything. It's that being seen, being heard, being validated, being acknowledged that matters so much. Yeah.
Yeah, I agree. I agree. I guess I would ask both of you, Dr. Tampa and Gurpreet, what comes to mind for the beginnings of this conversation today?
Let's start with Dr. Tampa.
I think that there's a lot in that poem, and obviously there's a lot in terms of the experience that Gurpreet has had and what she shared. I think from a doctor's point of view, we can either start with I suppose, the symptoms, the initial symptoms, or we can talk about the training that doctors have. But I suppose the symptoms, because I suppose the biggest issue is the symptoms that lead to suspicions of a diagnosis of endometriosis. And so the difficulty that I think that doctors have is because we think about 10 to 20 different diagnoses for all of these symptoms. So the painful periods, the irregular bleeding, the heavy bleeding, there's a few different things that we think about potentially causing them. And so when we meet a patient with these symptoms, we're trying to be objective and neutral. We're trying to build rapport, but at the same time trying to be scientific in our approach in terms of, okay, these are the symptoms that you have. These are the problems you're experiencing. What are the likely causes? What are the likely treatments? And before we can discuss treatments, we need to have a diagnosis. And the challenge is then, okay, so it's unclear. There's, the symptoms are sort of coming and going. They've been on for some time. And so it's just a journey of getting to a diagnosis. But with endometriosis, often you need a biopsy. And if you don't have a biopsy, you don't have a tissue sample, you have a suspected diagnosis, but you don't have a full diagnosis. And so for many patients, the difficulty of having a diagnosis can mean that they often give up on their doctor, or they give up on getting to a diagnosis. And so you don't necessarily have that rapport, or you don't necessarily have that continuity with the same doctor. And so you can end up jumping from one doctor to another and trying different things that don't quite work because you don't have a diagnosis. But I can appreciate if you need a diagnosis to make sense of what you're experiencing, and you feel like the doctor isn't helping, or they're being deliberately sort of obstructive. That can be quite annoying and quite upsetting, and you get into this cycle where the options are slightly limited. Imaging can help, whether it's an ultrasound or an MRI, but ultimately for endometriosis, my understanding is that you need to have a biopsy.
It's really interesting because I think that's one of the things that we touched on. It's that patient doctor relationship and what happens over time when you are going back and going back and going back. And for me, I call it survivor fatigue. If you are somebody with a chronic illness or condition, being able to, and maybe you can speak to this, Gurpreet, finding the energy and the strength to repeat, because it's the same information when it's over a period of time, a lifespan or however long. It's actually the same information. It may pattern in different ways, but it's often the same thing that you're having to advocate for. And for me, as someone who has been chronically unwell, I experience a sense of fatigue sometimes, which I don't even want to talk anymore. And I'm curious about your experiences of that in reference to what Dr. Tampa was just speaking on.
I have a very different experience from what Dr. Tampa was, speaking on. I think this is what actually made me write this book as well. If we say that endometriosis is a very rare kind of, illness, where only, a handful of people in the world have it. And then you go to the doctor and you say that, oh, this is how it is. And the doctor really doesn't know, because there are other various kind of, things that are going on, and a diagnosis is difficult. I would be very sympathetic to that situation and to the doctor, you know. We're talking 190 million women across the world. That is only diagnosed, the recorded numbers. If you look at the global south, countries like Africa, India, West Indies, where, people are not diagnosed with it. So if you actually bring all of the diagnosed, probable diagnosis together as well, the number is way higher. WHO has actually said that it outnumbers the people who have diabetes in the world. So my question then becomes that if it's that prevalent, how is it so mysterious and so not known? And the answer to that question also lies in probably what Dr. Tampa might, cover later on. One is how medicine is taught, how medicine is taught to doctors, how the medical curriculum itself is designed, where women's health, reproductive health is basically a touch and go. You're taught that, okay, endometriosis exists, but what is it like, you know, as a disease, and how it manifests in the day to day is not there. If you look at the definition of endometriosis, right? Tissue similar to the lining of the uterus grows outside of the uterus. Tells you nothing of what it is like to live with it. Nothing. Nothing. Right? And it's also a question of the prioritization that's happening in the health professions, right? Women's health and the funding that is needed to go into the research for women's health is simply not there. So I think I really beg to differ. So Dr. Tampa, I'll give you just on the top of my head 2 experiences that I had. So I was in a wheelchair, doubled over, crying, begging in pain, so much in pain, and went to a very, very senior, consultant who is a specialist in endometriosis, adenomyosis, etc. And he didn't lift a finger. He saw me crying, and I was begging him. I was like, "Can you please help me? I don't. It's so painful. I don't know what to do." And he looked at me, and he basically was like, "I think you're not having enough sex. You need to have more sex and produce a baby and get pregnant." And I'm not the only one. I'm not the only woman, in this room who's actually had something like that said to her. This is a very common statement that is given to, a lot of endometriosis patients, survivors. You talk to any woman who has been in that situation, she will be able to tell you at least one incident where one doctor, no matter where in the world, would have said that to her. And the second one, again, couldn't walk, doubled over, I rolled into his office because I was in pain, and I'm crying, and I'm telling him, please help, please help. He laughed, and he said that, oh, I played tennis yesterday after a very long time. My elbow is also hurting, you know? So, and these dismissals they are the cornerstone of why it takes so long to get diagnosed. And it's the reason why the doctor-patient relationship gets cut short, because when you are told these things in that state by a doctor who is supposed to help you and work with you, believe your testimony and not dismiss it by saying these things, you can't have a doctor-patient relationship.
Um,
You can't.
that's really interesting, and I think it's heartbreaking to hear as well. And I'm really sorry that was your experience. There are a few things I can pick up on that from my own personal experience, but I want to move it to you, Dr. Tampa, and raise that question around training within the medical profession around women's health. and what that looks like, because I guess there are, for women who do have these experiences, there are often experiences that would go under the title of feeling dismissed, feeling disbelieved. And it often creates this question of, why is there not more knowledge? Why is there not more understanding within the profession, it seems, around these things? What is happening in the training space that's creating this disconnect between doctor and patient?
Yes, I think it's a difficult question in the sense that there's lots of different factors to consider when it comes to training. Obviously, number of training school, I mean, a number of medical school places, the length of training, how much money is dedicated to placements, how long these placements are. You know, but I would say that, you know, in terms of my training, because I can talk about my experience exclusively. I did a graduate entry program. I studied engineering before I went into medicine. And so you have medical students who can either be postgraduates, so people who've already studied beforehand, or people who've, you know, are very young and gone from college, you know, 18, 19 into university, and haven't got any other life experiences. So generally, it's there's a component which is, you know, the practice of medicine, so sort of, you know, ward rounds, being on the ward, seeing patients, following like an apprentice. So you sort of learn through interactions with your senior colleagues who are actually working in the hospital or in the clinics. And then there's the theory side of things, which, you know, helps give you a foundation to understand, you know, disease processes and why things happen and how things can be confirmed or diagnosed and so on. But the actual practice, you know, the part that, you know, is the biggest factor is, you know, ward experience, clinical experience behind a supervisor or a trainer who's actually, you know, doing the job. But I suppose in terms of in terms of the difficulties or the challenges with training, I would say there's this thing about common things being common. So just to say that we don't always look for the sort of unlikely. Well, I appreciate when it comes to numbers, it may not be as unlikely, but we try and look at the most likely diagnosis based on the symptoms, based on the presentation. So, and I mentioned obviously dysmenorrhea, so painful periods, menorrhagia, heavy periods, bleeding in between the periods, post-coital bleeding, bleeding after intimacy. All these are sort of the symptoms that women may have. It's not one thing we're thinking about. We're thinking about fibroids. We're thinking about polyps. We're thinking about cancer. We're thinking about, you know, PCOS. We're thinking about all these different things, and they're all diagnosed in similar ways, but they have different requirements for an end diagnosis. And then the treatments vary as well, depending on what the actual diagnosis is. And so, unfortunately, you can have someone who has, say, symptoms of endometriosis, and you think of it as a potential diagnosis, but it's on a list of, say, 10 or 5, let's say. You have to work your way through as per the training. So we think it could be endometriosis potentially. It's more likely, say, PCOS, or more likely sort of a casual term, dysfunctional uterine bleeding, which is non-specific. It doesn't really, it's not a full proper diagnosis, but sometimes women can have dysfunctional uterine bleeding, which again isn't the same as endometriosis, but it can present in a similar way. And so in time, with either treatment or with trials of therapy, you may then confirm, no, it isn't dysfunctional uterine bleeding, or yes, it is dysfunctional uterine bleeding. But then if you're not winning, if you're not getting a solution that works for the patient, you would then, or there's red flags or the symptoms that are very concerning, then you would refer to a gynecologist who would do more assessments or do more have a greater range of options to treat and manage the condition.
So it sounds, sorry to jump in there. It sounds like a really complex process of, what's a simple way of saying it? Whittling out what it isn't to get to what it
Yeah.
is. But obviously, in terms of the patient's experience, that's extending the period of going through it to get to a point of diagnosis. And during all of that, there's going to be various treatments that happen. To me, that sounds like we're speaking to the complexity of how a woman's body operates, and all the possible conditions that a woman's body can suffer, which then brings me back to the training space. In terms of your personal experience as a trainee physician, and then being a practicing physician in the field and seeing what's really happening in the world with your patients, do you feel that there is adequate training around women's health? Because it seems like that there's so many of, I'm going to say us, because I'm also within that contingent, who have had incredibly difficult, long, protracted journeys within the medical profession, trying to find diagnosis or solution.
I suppose because we can work with ideals, and in an ideal world, yes, every doctor would have longer training and they would spend more time learning about women's bodies because they are more complex than men's bodies. But I would caveat that by saying that all these things come at a cost, and that cost is often money. When it comes to, say, training a junior doctor, so just to go from zero to sort of 5 years of training, it's something in the order of, I think, 300K apparently. I think 300, 500K to train one doctor. I was a bit surprised by that, but it is very expensive to train one doctor because they have to often pay for the clinical time and other sort of additional materials. But yes, I suppose in terms of answering your question, we probably don't have enough time that's dedicated to women's health, or I suppose obstetrics and gynecology, which is the sort of field that we sort of talking about. And in terms of my experience, yeah, we did, I think, a fairly, because you have to do modules in women's health. You have to do sort of things on sort of maternal health and gynecology and various things. But the placements are like I said, the most valuable thing, because you see patients who are having problems and you talk to them, you examine them, you see cases, you go through cases, you learn on the job with someone who is working with these women. In my experience, I did, from what I can recall, in my second year, which was the normal third year. So that typically the first 2 years are pre-medical and it's sort of book learning and then lots of exams. And then the third year is when you start the clinical rotations. And so the focus in the third year is more sort of the main systems. So cardiovascular, respiratory, gastrointestinal. Yeah, those are really the four main systems that you sort of focus on. And then in the fourth year, that's when you have the specialities. So you have psychiatry, you have obs and gynae, and you have to do, because I had to see a certain number of pregnancies, or a live birth. I had to see a certain number of live births. I had to be signed off for a certain number of examinations. But yeah, I mean, ideally you would see more, because obviously more generally is better, but the greater depth and greater range of conditions, a greater range of cases, because it's like machine learning to some extent, pattern recognition, understanding how things present, and then having that sort of template sort of to sort of yeah sort of record.
But then, sorry, I cut you off. Finish.
Yeah. I think the thing as a GP, because this is maybe the biggest sort of thing I would take away in my GP training. um, there was a plan to move towards 5 years. At the moment, it's 3 years of training, and 5 years would encompass so all the specialities, and you'd spend 6 months with each specialty. So peds, 6 months, gynae for 6 months, psychiatry for 6 months, palliative care for 6 months. But because there wasn't the funding, they couldn't extend it for the 5 years, and now it's still 3 years. And so this was something that was proposed sort of way before COVID. And so unfortunately, I didn't get the chance to do the 6 months of gynae. I did palliative care, or end of life care. I did psychiatry. I did acute medicine. I did general medicine. I did 18 months of general practice, and usually that's enough because 10, 20, 30 years ago, GPs were becoming GPs after their general training, the 5 years of medical training. And so that's just to say that things are always changing to improve standards and improve the doctors' sort of skills and to update them. But there's often a funding issue, and if the funding isn't there, you can't necessarily
you can't go in
put
depth
place
with
these
one
things.
particular.
Yeah.
So that I'm wondering how that then translates for your experience in the room with your patients who are coming in with these complex symptoms, which can look one way one week, can look another way another week, can look a certain way at a certain point in their cycle, and then because that's what our bodies do. I'm not talking about every condition, but that is, one of the tricky things about how our bodies work. How does that then impact when you're coming into the profession and you're working with patients and they're coming in with these complex range of symptoms that seem to be springing from all over the body, and in different ways? Relationally, what's happening with you and the patient in that space, in your experience?
How do you mean? Sorry. What?
When just ultimately when somebody is chronically unwell, one of the key people in the experience is the medical professional. Because what tends to happen, and please jump in, Gurpreet, if there's anything I don't cover, what starts to happen for the person who is unwell, and I'm sure you've experienced this as well, is a question around, is this real or not? How do I prove this? Especially if it's not visible. If I say that my 10 is a 20, that my pain is a 20, and I can't produce evidence, oftentimes the person who is suffering almost requires desperately for a medical professional to validate that experience with whatever medical means or certificate, whatever, so that not just for the person, but also for the people around the person, because they're also experiencing these symptoms and questioning, is it that bad? And I guess being in the room with somebody who is a long-term sufferer, if you are as a GP seeing that person time and time again, and let's say, for example, the symptoms aren't adding up to a diagnosis through the systems that you're using, or if you've sent them from multiple tests and we still don't have an answer, how does that then impact your relationship with the patient and their relationship with you?
Well, I suppose, we're human, so we can become frustrated in the same way if we're not making any progress or we're not getting any answers. But we try and have a positive relationship with the patient, one that's conducive to us being able to help them, and whether it's offering pain medication, referring them to a pain specialist, or dealing with there's a whole range of there's an area of medicine for unusual symptoms, and there are sort of doctors who specialize in patients who have atypical, unusual symptoms that persist and are not fully understood and not fully defined. like chronic fatigue and sort of IBS type conditions and things that sort of just go on, and there isn't necessarily an end, and it's more about managing it in a way that makes it survivable. People can still get on with their life, or they can still have some quality of life. Especially when it comes to myself, I always try and look at how we can get answers, or what else is missing in terms of the picture that we have. And so the challenge is always to maintain that relationship, maintain that rapport, and just look at what we do know, look at what's subjective, what's objectively true, what we can confirm that we've done in terms of assessments and procedures and tests and trials of therapy, and what has worked, what hasn't worked, and what needs to change. And so it's just working with the options that are available. So whatever the options that remain, if it's a question of managing the psychological impact of the condition on your health, obviously seeing a psychologist, a therapist, talking to someone about your condition, looking at support groups, going to charities, organizations. So a lot of it is signposting, because again, not all these things are accessible on the NHS, and patients may want to pay privately, or they may have to pay privately if it's not accessible. Or looking at resources, books and videos, or sort of music as therapy, and or different kinds of interventions that can help, because not everything needs medication, and not everyone wants to be on medication. Where you can offer really strong opioids, but that may not be appropriate for a mother who has children, or so. You look at the options that are available and then just go through them with the patient. But again, these are within the constraints of having 10 minutes per consultation. And so again, it may
So
not be
that's another
satisfying.
tricky thing. So it's not just the finances, but it's also how much time is being given to patients, or able to be given to patients. Because the 10-minute consultation with someone who's got complex, that in itself structurally doesn't really work and isn't realistic for GPs, let alone patients, is it? 10 minutes.
Especially if someone's upset and you have to respond to their sadness. You
Emotionally,
can't necessarily then to sort of rush them along. So.
Gurpreet, from your perspective, from that relational standpoint, what would you say happens between doctor and patient as this process is, I guess, prolonged and undefined for many individuals? What would you say happens there?
I think a complete breakdown happens. And I'm just listening to all of this, right? You put him on a spot, Pid'or. I'm going to put him further on a spot. I'm hearing metrics. I'm hearing, signs. I'm hearing symptom. It has to fall. Da 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 da. In all of this conversation, one big chunk is missing: listening to the patient. Doctors don't listen to the patient. Sorry, you may be you may be doing that, but in my experience, it's a checklist that gets performed, and you literally were talking a checklist. We have to it's like machine learning. Then you recognize pattern, da 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 da. Then you check 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 check. This is what happens, and when you are acutely in distress. I hated it when I was told you need to breathe. No amount of breathing was calming my pain. I hated it when I was told that I'm stressed. I don't know what else you all expect from a patient who is hitting a level 20 in pain. The patient is also human. They're bound to be stressed, I hated it when I was told that, this is all psychosomatic. No, the problem wasn't here. The problem was in my pelvis, and it's not atypical representation, because that's what I'm saying. Doctors don't listen. Every endometriosis patient will come and tell you very, very, very similar things, pain, pain, pain. Pain starts at the back. This is cyclical. I'm missing school. I miss school. 3 times, 3 days in a month. I fainted from the pain. How are you not connecting the dots? Yes, there may be other things, but some of the things are so commonly said, that I can actually sit there and tell you that's not a fibroid, that is not PCOS. What you're talking is endometriosis, and I'm not a medical trained doctor, So, and a lot of times what happens is that there's a bit of tunnel visioning that goes in doctors. So when I ended up on the wheelchair, gynecologists that I was seeing would ask me, but why? Why? Why is it that you can't walk? Uh, you know, it's your core that is affected. How are you supposed to walk when your entire core is just gone off the charts with pain? Your core supports you, enables you to walk. So what are you talking about? So in my experience, Pid'or, the main core that is missing, even in this room as we were talking, right? We're talking metrics, metrics, metrics. But the main thing that was missing, you're not listening to the patient.
Mm.
You're not listening. And as much as we have, patient-centered outcomes in, say, cardiovascular diseases, so heart attacks or whatever, patients with heart conditions will say that we'll put patient first, right? In endometriosis, it's the opposite that happens, right? The patient is never listened to. So the testimonies that we give doctors become very important. We are telling you what we are going through on a day-to-day basis. That's evidence, that's literal evidence of suffering, of pain, of what it is. And yes, in your 10 minutes, you can't even imagine what the 24 hours day looks like. In your 10, you get up in the morning, you get ready, you come to work, you start seeing the patient. I'm the patient. I couldn't even open my bowels in the morning because I collapsed on myself in pain.
Mm.
So in this entire equation, the main thing that is absolutely missing in the doctor-patient relationship is not just validating the patient, right? Is listening to the patient, believing the patient, giving an intervention that, yes, you're, oh my God, sorry, I'm going to say this, right? You're in fucking pain. Let me alleviate your pain. Let's get you in a position where you're comfortable right now. That is the main priority. Let's get you out of this pain. Then we'll talk. Then we'll see, okay, what needs to be eliminated? What needs to be done? But you're leaving the patient in pain. And you're saying that, oh, this checklist, this checklist, this checklist. So it completely destroys the doctor-patient relationship from the patient perspective. Completely.
Mm.
I don't need music when I'm in pain. I need my pain to be alleviated. I need my pain to stop. I don't need a therapist at that point in time. That can come later. I need my pain to stop.
Yeah.
Yeah.
And I guess in listening to you, I'm curious about, if it's okay to ask this question as well, the relationship with pain. I know, like, in terms of my condition and my life experience, what my relationship with pain has been. And I haven't been diagnosed with endometriosis, although it was something that we were investigating as a possibility. Um, and I guess I'm curious about the lived experience with pain day to day. What does that look like? What does that sound like? What does that and obviously I will share this with the cast, because this is a really detailed depiction of it. But if you could caption that for us today, how would you express that?
I think one of the things that I first said somewhere, I think in the preface, and I even said this in my TED talk, is that it's a pain that defies language. It can't be captured with language. I don't have any metaphor, any simile to give you because it just wouldn't capture the severity of it. So, can you begin to imagine a pain that can't even be imagined in the first place? Right? That's the whole paradox of it's so severe that it breaks you. It broke me. It completely broke me. And the added, pain of that pain is that, like I said, doctors don't believe you, you know, family will then, because it's a very hierarchical relationship, strangely, this doctor patient relationship. There's a lot of power involved. It's hierarchical. The patient has no power, right? It's the doctor that is actually, given that power that, oh, you're the expert here, you know it all, you know best. And the family tends to believe the doctor over their own family member. So that creates an added, kind of tension because when your own family members also don't believe you, how can that be possible? The doctor also said it can't be that bad, you know? Um, then the patient is completely isolated. You don't have anyone to not even talk to, but even validate that. Then you go into a spiral of how is this possible? Is my body lying to me? How can the body lie to me? I am going through this, right? That's what I said, that the testimony needs to be believed. And that is hugely missing in this entire, equation. And living with that pain, it destroys you. It destroys your sense of self. It destroys your. I couldn't even see a future for myself, Pid'or. I was on that wheelchair for almost 6 years, 5.5 to 6 years, multiple surgeries. I went through 6 surgeries, 5 nerve blocks, and ultimately a total hysterectomy. And my life was 4 walls of my parents' bedroom, not even mine, because there were stairs to climb to get up to my bedroom. I couldn't climb stairs. I was confined to my parents' bedroom and the hospital OT, and that was my life for 6 years. I couldn't go out. I had to stop studying. My career was ruined, all taken off. And, and every time you'd hobble, you'd get pushbacks. Like I told you, doctors would tell you that, oh, it can't be that bad. Why can't you walk? It's not that your legs are affected. So there's the kind of tunnel visioning where your body itself gets very disembodied, right? Oh, it's this part or that, and it's not
Yeah,
viewed as a
holistic.
whole. Yeah, that is affected, that every body
Yeah.
part has a sort of a ripple effect, on each other. How do you walk, like I said, when you're doubled over in pain, right? And then I was on fentanyl patches. I was on epidural ketamine for 15 days, because they couldn't break the pain cycle. I was on oxycodone. I was on Targen. I was on PCA morphine, you name it, I was on it. I was doing like 475 milligrams of gabapentin or Lyrica a day that would knock out a person. That is what you're expected to tolerate and still perform, still
And
smile.
that's one of the things that if we can go into, how do you maintain a sense of self in that?
I had no sense of self. My sense of self was completely destroyed. I became a shell of my former self to the point that, when I came out of this ordeal on the other end, I didn't even know who I was anymore. And this is the other disconnect that happens with people around you, even with the doctors, right? It's expected that, oh, it's like an on-off switch, you know? Oh, but now this is done. Snap your fingers, get back to it. How do you get back to it? You know? Um, it's it's so bizarre that, when a person with a heart attack, comes and tells you that, oh, I had a heart attack, they're actually given, you know, they're given a lot more empathy, a lot more recovery time. You must take care of yourself, da 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 da. How come that is not there when it's endometriosis, right? And like I said, there's a lot of gender biases that actually happen. And they're not conscious. A lot of doctors will say, no, 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 they're not conscious, but they're there. The number of times, uh, I got called hysterical, attention seeking, drug addict, you know. My mother was the champion of that. She was like, oh, you become a drug addict, drug addict, drug addict. How do you stop believing your own daughter, who you've known your entire life, who has studied, who has worked, who has not abused drugs in her, whole life before, suddenly when she's in this much of pain and has to take these medications, she's suddenly told, oh, you're a drug, like that, overnight, you're a drug addict. So your sense of self, the pain, the attitudes that family members give you, the attitudes that you get from doctors, all of this combined, poof, it's gone.
That's a lot. I'm listening to you, and a question's coming up for both yourself and Dr. Tampa, which is about and then I want to hand over to the actors in case they've got questions as well that would help support their characterization work. But the timeline, I'm curious about that. Within the story of the play, we meet the character when she's first in going into secondary school and has her first period. We understand with endometriosis that it's not purely about periods. It's not just about the womb, and actually it can exist pre-menstruation beginning. And I guess I'm curious about, for your journey, Gurpreet, when your symptoms began, um, and whether the intensity it sort of increased gradually, or what was the journey with that. And then for you, Dr. Tampa, I'd also like to come back to you in terms of patients that you've seen and what their timeline has been like, and what their presentation has been like, if you've had that experience as well.
Would you like me to kind of tell you the
Yeah,
second?
sure.
Yeah. So I'll be very open, right? I got my periods quite early. I had them when I was 11. I was still in primary school, and I then started having very painful periods by the time I was 12, to the point where once in school, I almost OD'd on Panadol because I just needed the pain to stop. And the only thing I had on me was a Panadol, and paracetamol basically. And I took 6 at one go and nothing happened. And I was, kind of went back somehow, and I told my parents that, I'm in so much pain. I took 6 Panadols at one go, freaked out, you know. Um, but that was basically, that should have been an alarm bell at that point in time, that that kind of pain is not normal.
It's not normal.
Is not normal, right? But the alarm bell didn't go off because you're told that, oh, every woman, every girl
You'll get
goes
used
through,
to it.
yeah, every girl goes through it. You're just, making a big deal out of nothing. Just keep taking the Panadols. You'll get through it. So by the time I actually reached when I was 13 and got into secondary school, I started missing school, about 2 to 3 days per month because it was absolutely impossible. And that was when, and this was way back, this was in the 90s when, a lot of the products that you have now in terms of like oral contraceptive pills and all, so many that exist, they didn't exist. There was only one option that used to exist at that point in time. And because you're so young, you're just 13 and you get put on the pill, your body also can't
It's a
tolerate.
crazy age to
No.
go on the pill.
Yeah, so
Yeah.
I started the pill when I was 13 and had so many horrible I was nauseated, I was vomiting, I got bloated, and I had to concentrate in school. I couldn't and they took me off the OCP after that. And then I went back into missing school. And the point of diagnosis, so like I said, right? So I'm 13 all the way to 12 when I'm, kind of doing this Panadol, and all the way when I was 19, first year as an undergrad, I fainted in one of the lecture theaters because of pain. And one of my friends had, she was sitting beside me, had the presence of mind. She, those times it used to be a Nokia 8250, phone. She took that out of my bag, okay, and kind of like scrolled through and found my, mother's number. And she called my mom and she was like, you just need to come. She's fainted. I don't know what has happened, right? So both my parents came. I couldn't walk. I was in so much pain. They literally had to carry me, and then, I said, I just can't walk. You have to bring your car down from wherever it is. I can't walk with the pain. And it got so bad that I my father freaked out and he's like, I don't think we should even go home with you in this state. You fainted. Let's go to the, emergency department. We went there, they got me admitted. And the doctor came and he's like, it doesn't look good. We're going to have to perform surgery. And I didn't even have time to, kind of mentally prepare
Yeah.
myself for anything or whatever. I couldn't tell anyone. I couldn't inform any professors that, hey, I'm being wheeled in for a surgery. I'm going to be absent. It's going to affect my grades. Nothing. There was no time.
Yeah.
And I was just wheeled in, and I couldn't even process it. And that was at 19, was when I had the surgery. That was when I got my diagnosis that it was endometriosis. After
That's eight
all of this,
years.
yeah, yeah.
That's about 8 years.
And that's the average. The average is 7 to 9 years that a woman goes through, you know? And it's not that I wasn't seeing doctors, right? I told you I was on the UCP, et cetera, et cetera. But you just kind of, like, all the band-aids are kind of slapped on, right? Without actually kind of, saying that, okay, it is endometriosis. Now we have this diagnosis. Now we have, now it's a treatment plan. We'll have to work with you and see what works best and kind of do that. That is where it doesn't happen, right? That's where you are kind of, you know, treated like a guinea pig, literally, right? Trial and error. Oh, this hormone. Oh, that hormone. This works. That doesn't work. And like I said, it goes off a checklist rather than
Yeah.
listening to the patient and hearing what she's saying and connecting the dots that, oh, okay, her history shows that, in the day-to-day basis, this is the pain, this is how it looks like, maybe this is not right, that is not right, so that doesn't happen.
So
And
eight years in your experience. And then
yeah.
if I hand over to you, thank you, Gurpreet. I hand over to you, Dr. Tampa. Does that track for your experience as a doctor as well in terms of any patients you may have seen who've ended up with a diagnosis of endometriosis?
It depends. Some patients who've got a strong family history, I think the youngest was about 16. But yeah, I think often it is sort of mid-20s or sort of, yeah, women have had symptoms for many years, and they've had assessments, they've had a few things done. But it can be difficult. Because like I said, ultimately you need a tissue sample, you need a biopsy, and a laparotomy where they do a procedure, they cut you open or they put a probe into your pelvis. It's not something everyone wants to have done, but obviously if you're having symptoms for a very long time and symptoms aren't improving with anything that's been tried, yes, that would be the approach. I mean, an MRI can sometimes help, an ultrasound can sometimes diagnose it, but it's not always definitive. It's not always enough. Even if you have suspicion based on an MRI or an ultrasound or symptoms, you often need to get a tissue sample, and a pathologist has to look under a microscope and say, yes, this is endometrioma. It's not cancer. It's not this. It's not that. But yes, it can take a long time, and I know there's work being done to sort of try and reduce that time. But I think the challenge is there's no cure. There's no definitive cure. There's no treatment that gets rid of endometriosis other than a hysterectomy. And for women who potentially want to have kids or want to have a family, you don't want to think about a laparotomy that can go wrong, and then you end up having to have a hysterectomy anyway, or having a hysterectomy when you're very young.
And the hysterectomy, because endometriosis doesn't just exist in the womb or the womb space, a hysterectomy is not automatically going to solve that necessarily as well. So there's that as well, isn't there?
Yeah, because if it's in the bowel, you need to have a bowel surgery. If it's in the lungs, you need to have, say, an operation on the lungs or something. So you can end up, having lots and lots of surgery with all the complications that can arise. And there's no good options, So, but yeah, it's a very tricky, difficult disease, very challenging, and yeah, there's not much that can be said, because I agree. Sometimes doctors aren't great when it comes to communication, and we have this thing where we try and again build rapport and hear the patient. We try and get ICE, so ideas, concerns, expectations. And it's not just something we do rote, but it's something we're encouraged to do. When we're having a meeting with a patient, we ask them about their thoughts about the condition, what their main concerns are, what they would like to happen. But we're not always in a position to realize these expectations. And we try and communicate that, but at least if we've asked the questions, there's a chance that that's been shared, and we have a better understanding of where the patient is at and what we can do to try and help them. But it's not always possible.
Yeah. It feels like being between a rock and a hard place. This is not feeling, like we are necessarily moving forward. It's hard. This is a really tricky situation. That's me putting it incredibly lightly, because it's not that. It's worse than that. Kiara and Pollyanna, I want to just hand over to you in case there are questions that have come up for you that you may want to ask either of the guests around points that have been raised, or things that might support you with character development or understanding.
I think something that's really interesting for me is I think C's presence and Z's friendship to Wrinkles is so much more important now, after hearing those experiences on how lonely it is, and how when you've got nobody that believes you and it feels like no one's believing you, and the fatigue, the exhaustion of having to repeat the symptoms and coming feeling like you're starting at square one, and why it's so important that Wrinkles has Z, who is that person who is there when Wrinkles is too weak to advocate for herself, or so yeah, I feel like I've really understood the importance of that role now. And I guess my question is kind of how it was at the same as it is in the beginning. I mean, it's interesting to sit like, hearing those reactions that you got from your mother as well, about like, is it, is this something that Z is feeling as well? Is it a real pain? Like, the importance of that diagnosis for not just the person, but for the people around them. And what my question is really is, what does it look like for the people who are supporting that person? What does it look like in the hospital or in the GP when they're sat next to the person who's suffering from this pain? Is it always like, how does it, I'm just trying to understand how Z would come at it. Would it be that they would talk on behalf of wrinkles? Would it be that they would sit and listen and just hold the hand? What is most helpful in those situations? What does the person who has endometriosis, what do they need from the people around them? That is my question.
I think for me, it was very important that my agency as a patient was not taken away from me. I was the one suffering, and I was the one going through everything, you know? So how can somebody else, like when I left the problem is because people don't believe you, they will interpret it in whatever way they want to. So, for example, when my mother, I think at one point she just didn't want to acknowledge and believe that the pain was so severe. She just told the doctor, "Oh, she's stiff today." And I looked at her and I'm like, "I'm not stiff." And she's like, "No, but you said you're stiff." I said, "I never said I'm stiff. I never even said the word stiff. I said I'm in pain, you know? I said that is what I was saying." So I think it's very important for the patient to be able to have that agency to put it out there what they are going through, and when, like you're saying, as the person who supports them, as Z who's going to come in and support them, I think, yeah, it's that, it's holding the hand, it's just having a presence there, it's that moral support, and it's that when the knocking down starts happening, right? When the doctor doesn't believe you, when the family doesn't believe you, when the friends come and say that, other people come and say that, yeah, it can't be that bad. That's when the advocacy really needs to happen, right? That, hey, if she's saying something, why aren't you believing it? You know, isn't it your job as friends to support her when she needs it? That's when the stepping up needs to happen. When the doctor, says that, oh, it can't be that bad, and then having her being there and saying that, oh, come on, I mean, she's saying that, why aren't you believing her? That kind of a thing, right? So it's not speaking for, her, but I think having her back, solidly having her back, so that she knows that no matter what happens, she has you to fall back on. She has you who believes her. And that, whether the whole world can actually turn around and say, I don't believe you, she has that one friend who is so rock solid and is not going to, turn her away and say something like, no, I don't believe you. That safety, that psychological safety, emotional safety that friend can provide, that is, I think, so important. Yeah.
Thank you. I'll hand over to you, Pollyanna.
I don't really have any questions at the minute. Honestly, everything's kind of been answered. Nothing at the minute springs to mind. Yeah, the timeline was very, very helpful.
Thank you. I want to say thank you to both of you for joining us. It is a really difficult conversation. It's a really difficult theme and subject matter. It's a really difficult experience. Thank you for sharing your views, your experiences, your thoughts and your ideas of also how things need to move forward. It's clear to me that there's still a lot of work to do in this area in terms of supporting women in having a better quality of life, even if there isn't yet a cure for this, which we pray there will be soon. But there's obviously a lot that needs to be done in the meantime to support a better quality of life. Thank you everybody for being here today. I've picked up lots that I think is going to help with developing this, and so much of what you've said actually ties in really well with what's been written already and the conversations that we've been having. So that's really makes me feel quite confident that we're going on the right track and that we're representing this in a way that is honoring people with endometriosis. So if anybody's got anything else they want to say, then please do. Otherwise, we'll hand over to Gurpreet to close the meeting with a reading.
Thank you, Pid'or. That was amazing, and thank you as well, Dr. Tampa. Couldn't have been easy, of being on the other end, of this. It takes that vulnerability as well, right? As a doctor and a physician to kind of come into this space as well. So thank you, for that. And I'll end it with this reading. This poem is called Inheritance. 5 years inside this furnace, and still they tell me to wait. 5 years of nights gnawed open, veins burning with chemicals, organs mutinying in silence. I have learned to listen to the wreckage that outlives language. End it, cut it out, empty the house of pain. I name my freedom, and my brother rises like a verdict, his voice a gavel, as if my uterus were his inheritance. No, you will regret it. You don't know yourself. But I do. I know myself. In the sheets that reek of rust, in nights where pain unthreads the hours, in mornings that arrive already broken. My mother follows, her disapproval sharper than scalpels. What kind of daughter speaks when her brother is the voice? What kind of woman chooses ruin? But this is not ruin, this is reclamation. They cannot taste the acid in my bones. They cannot feel the knives grinding through tissue and time. Yet they would rather see me suffer than release their claim on my body. This is the inheritance they handed me: pain, endurance, disapproval, denial. But I will not carry it any longer. The hysterectomy is not despair. It is the last door left unbarred. The only doorway where my pain does not follow. If they wanted me whole, they should have loved me whole. Now I tear the last inheritance away, and in its absence, finally breathe. Thank you. Thank you.
That poem hit me the first time I read it. It says it all. Thank you so much for sharing that. Thank you for sharing your experience and contributing to our process of developing this piece of art, which we hope will continue the advocacy work for people who are living with and
When is it
surviving.
showing?
The
When
29th
is it?
and the 30th of August. So if you are back in England,
Fingers
you
crossed.
must
Yes,
come.
I'll definitely, come for it. If I hope to be there by that time. So hopefully I'll be able to catch it.
We'd love to have you. But when you are
Yeah.
back in London, do get in touch with me because I'd love to meet up with you anyway.
Yeah, let's do that. Let's all kind of, go for coffee or something. Yeah, that would be lovely. Yes. Yeah.
Thank you so much.
Perfect. Thank you.
Okay.